So thank you. I wanted to thank the organizers of the conference. Thank you, Juan and Erica, for the invitation. The conference has been very interesting. And I'll just say a few words about my background for those of you who don't know me. Right now I'm working as a full-time family physician in Seattle area, but that was after about 14 years in Bishkek. The last 5 years that I was there, did some work on a regional USAID project that also took me to Kazakhstan and Tajikistan plenty of times. So many of you I know, and it's very nice to see you again. I started helping with the introduction of family medicine as a specialty in Central Asia, and Kyrgyzstan was one of the first countries that started doing that, and helped to train some of the trainers that also came from Kazakhstan and Tajikistan, and that eventually evolved into doing more on quality improvement at the primary healthcare level, and then we also connected that with helping support initiatives on evidence-based medicine and clinical guideline development. So this topic is very dear to my heart, and I think critically important. So let's start with that question about clinical guidelines or protocols. Do we need them? And I think the answer is a resounding yes. And from the discussion we've had so far, I think most everybody in the room, I think, would agree with that. There are issues that we need to address regarding content of care, and clinical protocols provide the opportunity for us to set evidence-based standards and tell providers or help providers know what they should be doing and what they should not be doing. And I would say in the Central Asian context that what you should not be doing is sometimes just as important or maybe more important than the other question, because often there's a lot of things being done that should not be done. Medications being prescribed or procedures being done that at the best are not helpful, and sometimes I'm afraid might be harmful. So the protocols can help us achieve that and decrease variations in practice at the primary and hospital levels. So what we certainly found, I think, in all the countries of Central Asia, that it is quite easy to develop protocols, but it is very, very difficult to develop good quality protocols. And the country started by generally agreeing upon a development methodology, and as many of you have already mentioned, it's pretty easy to get a policy or some kind of methodology down on paper, but those are not always followed. And what tended to happen was you would get some buy-in from the Ministry of Health level, and the minister or deputy minister would say, great, please give us 200 new clinical protocols within the next year. And people would salute smartly and say, okay. And then you would end up with 200 documents that were not evidence-based, and certainly were not what we were looking for, and ended up, in some cases, I think, discrediting the process. So it is very challenging, and it speaks to the question I raised yesterday. The challenge is developing capacity to at the country levels to develop these good quality guidelines. And part of that is having a unit or a consultant, or either at the university or at the Ministry of Health level, that coordinates that process from start to finish and makes sure that whoever is responsible for developing the protocols follows the approved methodology, because that is often what does not happen. What we also found is that the protocols, it was very helpful if the protocols could include implementation indicators, and if they could include patient education material, and if they could include like a one-page summary or simplification or algorithm, like a job aid for the providers, that would make them more usable and easier to implement. And Kyrgyzstan actually did quite a good job with doing those things. the capacity, of course, needs to be developed in that evidence-based medicine unit, but also needs to be developed among the guideline developers. So in Kyrgyzstan, any group, let's say it's cardiologists or the OBGYN doctors that were going to develop a guideline, would be taken through training on evidence-based medicine, training on the methodology of guideline development, and then the last few years I was there, we started to train groups on indicator development, which I would be happy to answer questions about that, but I also think that's a very important component of this linking between the auditors, for example, and the providers. And if you do that right and you get good quality, usable, evidence-based protocols, there will be demand from the providers. And definitely in Kyrgyzstan, anytime providers would come from the region to Bishkek for a conference or something, they would often go to the evidence-based medicine unit and beg for the protocols and actually be willing to pay. And some, of course, they were not for sale, but often, unfortunately, Kyrgyzstan didn't have money to even print enough protocols to distribute widely throughout the country. So there are a number of challenges. So next, I want to talk some about audits, but since a few people asked a question about how do you implement protocols, so you get a good quality protocol, but it's very difficult to actually get through the implementation stage. And I think we can at least agree that some of the key players for implementation are the educators. So there has to be some kind of link with continuing medical education so that you can get what's on paper to the providers in some kind of an interactive training environment. The other group that's critically important in both Kazakhstan and Kyrgyzstan were professional associations of primary healthcare providers that helped with clinical audits. And the third group would be the purchaser, who I would call it quality assurance. They're the ones that do the audits to see are the guidelines actually being implemented. So there are two models that I would say that were used primarily in Kyrgyzstan. The first 4 years that we were working on quality improvement, it was more of what many of you might be familiar with, the methodology of continuous quality improvement, where the family medicine trainers from the Postgraduate Institute actually went to primary healthcare facilities, did some basic training on quality improvement methodologies, and helped them to prioritize problems that they felt were important to improving care. And then they would analyze that problem and implement their plans to improve quality and do some monitoring. And that went on in one oblast for a couple years. And the providers were actually very happy with it, but I would say that it led to more kind of cosmetic improvements, some improvements in the organization of care at the facility level, but because each facility was working on something different, it was hard to see that we were improving the content of care or outcomes in any systematic fashion. So in 2005, the responsibility for that was shifted to the Professional Association of Family Doctors, and this happened in Kazakhstan as well, where we tried to link the subject of these clinical audits to national health priorities and to protocol or guideline development, and just take one topic per year and develop a small set of indicators, let's say 5 to 10 indicators, and in Kazakhstan I think it was even fewer. Often they would just focus maybe on 2 quality indicators, and support the facilities to focus on those topics. So usually it was connected with some kind of training. There would also be some basic training on quality improvement, and then the professional associations would return periodically to do monitoring of the charts and to provide feedback to the providers on where they were in terms of the indicators. So that certainly led to more tangible improvements in the content of care, and we learned a number of lessons through that I have listed here. One is that self-sustaining quality, continuous quality improvement is very difficult to achieve, and particularly at the primary healthcare level. And what I mean by self-sustaining is that there's some kind of internalization of the methodology, the approach, where they start choosing their own problems to work on and using that methodology to improve, rather than waiting for somebody to come from the outside and say, let's work on hypertension or let's work on tuberculosis and use these indicators to do it. It does require a lot of ongoing support. And as you can imagine, when you have maybe in one rayon, you have 50 different FAPs or, and family group practices, for a professional association to try to visit each one of those even once every 3 months is very difficult and costly. We also found that having a champion for quality improvement, if you had even one person that really kind of grasped the concepts and took that on as a leader, it made a huge difference. And we probably saw that more at the hospital level than we saw at the primary healthcare level. It was very important to get buy-in from managers, and that was also a challenge because you would need to introduce them to the whole principles, do some training for them, and then it seemed that as soon as you got support from them, they would switch, and they would leave for someplace else and be replaced by another healthcare facility manager. And cultural factors, and I was happy yesterday to hear that culture was added as one of these dimensions of quality, because I have seen that as a very important issue in how quality improvement is internalized or is not internalized. And I'd like to say just a few words about that. I think in general, people are very supportive of doing something to improve quality. Most facilities want to improve quality. They realize there's a need to do that. However, continuous quality improvement, the cycles that we talk about, the plan, do, study, act cycles, and this idea of prioritizing your problems and doing problem analysis and deciding how you're going to measure it, it's a Western thing. It's a Western approach, and I think we have to realize that the culture in this environment does not always match up well with some of the requirements of that methodology. For example, doing team-based problem solving is not a culturally well accepted thing, because the culture here is more top down, as was mentioned yesterday. You are usually you do what you are expected to do, what you are told to do, and it was actually not encouraged to talk about problems, and nor was it always encouraged to take initiative to improve something. So it can be very, very difficult for people who come from a different cultural background to feel comfortable talking about problems openly, not just identifying the problems, but actually doing some kind of problem analysis as a team. So I just think we need to be cognizant that some of those cultural barriers, they're just differences, and we might need to find different approaches to different kinds of methodologies to improving quality. And let's talk about that next. That the second, briefly, these challenges. I already mentioned the effort it takes to support the primary healthcare facilities. Yesterday and today it was mentioned that managers of healthcare facilities often do not have a background in quality management. There's frequent turnovers of the managers. And then these last two things I think are important to mention. Data analysis is also not something that's taught in medical schools. So to be able to even calculate indicators, and that is something that requires a lot of teaching and support. So even in our cycles, every 3-month cycles of quality improvement, we often found that was one of the more difficult things for the facilities to do, was to actually calculate and track the indicators. But this last one is also quite important, just the problem-solving process. So when we would find that an indicator was low, for example, what would the response be? If you sit down together with providers in the facility and say, look, only, 60% of the patients who are diagnosed with bronchitis are still getting antibiotics, why do you think that is, and how can we improve that? The typical response is, well, we just have to teach them and tell them not to prescribe the antibiotics. But of course, that's already been said a couple times, and there are some other issues involved. But going to that next stage of a little bit deeper root cause analysis is a challenge in facilities, and but it's also where the meat of improvement lies. I think to understand why we are not following the standards of care. So let's move on and talk a little bit more about the second model of quality improvement that I usually refer to as audit and feedback. I think it is a more culturally acceptable approach, and I think that's probably why when we got the professional associations starting to do that it was much easier than the CQI type of methodology. One, it should be done in a supportive atmosphere. So instead of this inspect and punish typical approach that is taken, if you can get professional associations who maybe do not have the authority to do any kind of punishing, and so the providers know that and they feel it's a safer environment of an audit situation, then they are more apt to be open and discussing the problems, and also the data is more likely to be reliable. Sometimes we would find that when mandatory health insurance fund would come and do audits, the data might not always be reliable because providers would expect these monitorings and have charts that looked great, whereas if the professional association came in, they were more open to show them the everyday charts, let's put it that way. So we also found that peer comparison can be a very powerful motivator. So when the auditors the professional associations would come in and give results, they could also show them results of neighboring facilities or facilities in different oblasts. And if a facility sees that their indicators are much lower than, let's say, the neighboring Ryan, they will often respond very positively and work hard to improve those. Feedback during those sessions, it was a great opportunity to reinforce education and the standards that were in the clinical protocols. And then another advantage when all the facilities are working on the same improvement projects is that you can collate results and look at a regional and a national level. And as I mentioned earlier, if you are doing that, you can be very intentional about connecting your topics for clinical audits to the national health priorities, which hopefully have made it into the clinical practice guidelines. So one negative to this audit and feedback rather than a quality improvement methodology approach is that it tends to focus more on the clinical content of care and not so much on the organization of care. And I think it's important to realize that sometimes the content is okay, but how we are organizing services is not okay. And the audit and feedback done by, say, the professional associations might miss that. This last point is just that we did see that professional associations were well suited to develop kind of packets of quality improvement materials for the clinics. So that could be a potential role of professional associations in improving quality, is to take clinical practice guidelines or protocols and kind of translate that into a very usable system of indicators and audit materials. So just a couple challenges to mention here. I already mentioned about the geographic distribution makes it difficult to provide close support, but also if you have a FAP or a family group practice, for example, in Kyrgyzstan, where you only have 1 or 2 doctors, you cannot do any kind of self-auditing in that kind of an environment. There are not enough providers, and to get people out to that level to do the audits is difficult, and there's not always funds, not always enough money for to transport the providers from those facilities to the district level or to the Ryan level family medicine center. And then sometimes the content of care does differ between the district level and a more rural level just because of lack of laboratory services, for example. And so the audits might be affected by that. So on this slide, and we don't need to spend time on it, I just wanted to show some of these linkages at the different level, at the national level, at the more mid-level of management, and then at the service delivery level, to show how critical it is to coordinate these processes from setting of the national healthcare priorities, getting clinical practice guidelines that cover those topics, down to getting the content of curriculum at the medical schools in line with that, having the postgraduate education, continuing medical education, incorporate those into their educational programs, getting professional associations to help support this quality improvement, and then at the service delivery level with the healthcare and quality management and the clinical audits. They have to be linked in order to get the impetus to actually achieve our health priorities. And then just some comments about where there's maybe opportunities in the future. There's an example in Kazakhstan and one in Kyrgyzstan. Well, actually, Kazakhstan, Kyrgyzstan, Tajikistan all did some work on rational use of antibiotics. And one way that we responded to this challenge of calculating indicators at the health facility level was to develop an online program where audit results could be put in directly into this online program that would automatically calculate all the indicators and the run charts. So then the coordinators within a particular facility it would all be done. They could print it out or just show it on the slides and have all the graphs, and that could just be ready for discussion, basically. And that kind of program just automatically would collate the data, whether you wanted to look at a facility level, a Ryan level, oblast, or even a national level. And they're doing this in Kazakhstan with maternal child health, and my understanding is that it has gone really well. So, taking advantage of automation and online access. And then, of course, I don't see this happening in the next 5 years necessarily, but as countries move towards electronic medical record, that's a great way to mine data and also to have some of these things calculated automatically and reduce some of the reporting burden, which can also be one of the challenges of audit and feedback or continuous quality improvement. Doctors are very busy. They're already spending hours every day on just writing and reporting. So to add additional burdens of tracking this quality data can sometimes just be overwhelming. So to automate as much of that as possible. And then this third point about specialists. We've talked a little bit about this transition from specialty care to primary health care and inverting the pyramid. It's not always easy, and we have to go back to the question of capacity development. And are the family doctors, do they feel they can treat diabetics? Do they feel that they can treat hypertension as well as a cardiologist? Do they feel they can take care of somebody with tuberculosis and diagnose it? It's easy to ask that question. It's not easy to get the primary healthcare providers to the point where they do feel competent to do that. And I think it's worthwhile to talk more about the use of specialists at the ambulatory level, and instead of just having them sit there and see patients along their profile, get them to start working to support the primary healthcare doctors to expand their scope of services. So in other words, yes, we need cardiologists at the ambulatory level to see the very high-risk patients who have had valve replacement, or who have really severe congestive heart failure, but they don't need to be seeing patients with hypertension. And the OBGYN doctors, for example, at the district level, don't need to be seeing low-risk pregnancies. What they can do is take some of their time, 25%, 50%, to help do some of these quality improvement efforts to help support, in a very kind of not inspect and punish, but a supportive atmosphere, help the family doctors grow and become more competent with an expanded scope of services. And then getting the standards of care and protocols or the essential drug list, whatever it might be, into an electronic format that can be used at the point of care. I think that is where we should be looking, so that doctors don't have to go to a printed thing. In our day and age, it should be very easy to get it onto a smartphone where it's quick access and it can be available to answer clinical questions as they come up in a short amount of time. So thank you. That is what I wanted to say, and happy to answer any questions.